Thank you very much. Welcome everybody in the very early morning. So I don't have anything to disclose related to this talk in specific, but I think it is a very important talk because the phenomenon I'm talking about is for me the most influenceable phenomenon in secondary brain injury. And what scientist, physiologist discovered in 1944 was that in cortical areas, if they are stimulated by an electrical stimulus, the normal activity decreases to silence and takes quite a long time, it's 5 minutes here, to regain. And the second interesting finding was that even if the stimulus was on one electrode, the phenomenon ran all over the brain, and the recovery was just the opposite way. So there was a silence of cortical activity for a certain period. And it took many, many years that a research group took over the idea. It was at the beginning in 2000 and 2003. There was the COSPIT group, the first meeting of the COSPIT group. It's the Cooperative Studies on Brain Injury Depolarizations. And just to get an idea, the recognition of this phenomenon cannot be done by the normal EEG recording. You need specific amplifiers. You need to detect the ultra-slow frequencies and the high frequencies to get these signals of the slow potential changes and the associated decrease in electrical activity. And it's now has been the last year's venue in Miami, where the name changed from the COSPIT group to the International Conference on Spreading Depolarizations, which will be held in June in Japan this year. So there was obviously a technical development, and at the beginning when we started recording, we had these recording systems with jumpers and all these electrodes, quite difficult to get established in the ICU and to keep it running in the ICU. Now we have a more advanced technology. We just have to connect the device and we readily get this signal very easily on the monitor. And the beauty of such a monitor is that we can combine it directly to other neuromonitoring devices like brain tissue oxygen tension, CBF and other measures. So it makes it possible to analyze these phenomena on the patient bedside, and what Jan was talking about, to see related findings on brain metabolic or brain tissue oxygen changes associated with this phenomenon. Obviously there is a large interest to get this method non-invasively, but the problem is that with the non-invasive detection it's possible you get a suppression of cortical activity, but it's usually only if there are clusters of cortical spreading depolarizations, so quite a bad signal. And we know that the depression of cortical activity can also be caused by sedation or by any other thing. So it's quite insensitive to say that this phenomenon, this depression of cortical activity, which can be detected on the surface, is related to cortical spreading depolarizations. But there are some interesting studies. This is one group who tries to put a grid which is not practically usable now in the neurocritical care patient population, but which was able to detect even the spread of this phenomenon with some limitations. But this is just to show that research is ongoing, and the future could be that there's going to be a non-invasive detection of that phenomenon. I think that's a very important point. So what does the phenomenon mean in daily practice? How far do we actually know that it could harm the patient or is associated with secondary brain injury mechanisms? And it's very important to know that whatever you read in the publications, we select the worst of the worst patients for monitoring. And for example, in stroke, if you see the incidence of 100%, these are the worst stroke patients who get the monitoring device. And this is maybe not the same true for SIH patients, because a lot of SIH patients who get operated on get the device, especially in Berlin. And so maybe this patient population is the one who is more reflecting the whole range of different disease severities. but it's definitely not true for stroke, ICH, and TBI. So taking these incidence rates a bit with caution is very important. One of the most important papers that came out in 2011 gave us an understanding about this phenomenon more in detail, to understand what are the associated findings with this phenomenon. And we know that there are CSDs which can be associated with transient hyperperfusion, and this is actually a phenomenon which we think is protecting the brain. So not all CSDs may be bad, but we also know that there are several CSDs associated with a severe hypoperfusion, so the neurovascular coupling is actually not working anymore. So how to study outcome in these patient population and about that phenomenon? And I think we are not that far to talk about clinical outcome, morbidity and mortality. We first have to answer what's the outcome on the brain tissue level of this phenomenon. So we can stick in other invasive neuromonitoring parameters like brain tissue oxygen tension, and then as you can see here is that there are different associated findings: a small dip in brain tissue oxygen regaining to normal again, a longer dip, a prolonged decrease, and sustained hypoxia, and actually no association as seen in this study. So not every SD causes the same related effects on the brain tissue level. And also if we look for more advanced monitoring, this is an online microdialysis, so you get every minute and information. You see that significant increase in lactate, decrease in glucose. So yes, these phenomena matter, they make metabolic changes. And if you see a picture like that, you already see that the patient has at the beginning a normal cortical activity, and then these CSDs happen, and you see the decrease, regain of function, and then again and again and again, and this is a 5 hours period. And what you can see here is that the brain in this area never regains the same level of activity. So, and if you know that this phenomenon is energy consuming maybe 8 times more than a single seizure, then you know that especially the injured brain is at risk of getting into secondary brain injury. We don't know chicken or egg whether the ischemia are causing CSDs, whether CSDs are causing ischemia, but once a cycle of these clusters cortical spreading depolarizations starts, I think that's going to be quite deleterious for especially the injured brain. And so we wrote an editorial quite recently in Neurology about that phenomenon, and this is an interesting case study also published where the patient was orientated at the beginning, became deleterious, became stuporous, aphasic, and then the long-term outcome showed in MRI this quite interesting phenomenon, which is not related to large vessel vasospasm. It's more a cortical pathology, what you can see here. And if you know that this phenomenon is a cortical phenomenon, it's very likely that actually these CSDs cause these lesions on the cortical area of the brain, which we now call DCI, and which is not related to vasospasm. And this is the same in models in ischemic stroke patients, especially these clusters. Is the idea that the ischemic core actually could enlarge over the area of the ischemic tissue related to the MCA or to other territory. And in intracerebral hemorrhage patients, we found a strong association with the progression of edema, which does not mean that it causes edema progression, but it's a related phenomenon. We cannot only report associations at this time. And if we go back to animal studies and now to clinical studies, and if we think about mechanism of secondary brain injury, we realize that in all these phenomena we can find associations with CSDs. CSDs associations with seizures, with blood-brain barrier disruption, with indirect autoregulation. So from the patients who had normal autoregulation at the beginning and then cluster occurred, and then 1/3 of the patient had impaired autoregulation afterwards. So there is a timely association between these phenomena. I think this is quite important also because we have to question what can we do right now. And one association, again, an interesting finding is that there is a temperature-related association of the occurrence of cortical spreading depolarizations. retrospective data, observational data, with all its limitations. But what this group found is that especially patients with high body temperature over 39 degrees had a high incidence of cortical spread and depolarizations. So this is another point where we can say, yes, fever prevention may be very important for our neurocritical care patient population. This is also something you can already do. And we measure brain temperature in relation to the probability of spreading depolarizations, and you see brain temperature is exceeding 38 degrees, we get a significant increase in probability of occurring of cortical spreading depolarizations, but again, it's only an association. And we find the same association if we investigate blood pressure. This is also only observational, but at a certain time when blood pressure decreases a certain level, there is an increase reported in CSD. So maybe this could be a biomarker to, in future, relate the optimal mean arterial pressure, the optimal CPP on an individualist approach. So I think for now we can say that the relevance of CSDs lies as a marker for critically instability, metabolic instability, and I think it is a marker for ongoing lesion growth. There's one study who reported an association with outcome, and this is a large, again, observational study in trauma patients, over 100 patients, and the outcome was EGOS at 6 months. And you see two different phenomena, cortical spread and depolarizations, where some function is regained afterwards, and then these isoelectric depolarizations, meaning that actually there's a depolarization and then the cortex never regains function, which means that the cortex is already in a very deleterious, close to dying situation. And obviously, and I think that's very it's unquestionable that we found an association with these isoelectric phenomena with mortality or with poor outcome in this study. So this is not very surprising result. We just monitor the dying brain and say that these patient population has poor outcome. So I think this has to be interpreted in relation to the finding itself. So all is these bad. And I just show you a video, and in the video, this is 125 times speeded up video. So it's a very slow phenomenon. And what you can see is the changes in perfusion. The black color, blue color means a high perfusion, and the white color, low perfusion, risk for ischemia. And if you see these phenomena, it's the pig's brain running over the cortex, I think you can understand that a certain degree can be captured by the brain, and the brain can be recovered. But if you have these extent ischemic phases, it could be related to secondary brain injury. So maybe short hyperemic response is not bad, but it's very difficult to distinguish between the good ones and the harmful ones. And what we don't know, we just monitor at a specific area in the brain. So the same SD in the periphery could cause a deleterious effect in the perihematomal and the perilesional side. So it's quite difficult to go on with the idea of a treatment. And I think that's a very critical point, because if we now apply a treatment for every patient, I think that's the wrong way. And if we have to select the right patient population for such a treatment. There are several drugs which we do have in the pipeline which could decrease propagation, initiation, or the duration of these cortical spread and depolarization. And I put some of the drugs which could be influenceable in future and which are drugs that could be studied in terms of treatment of this phenomenon. And the most promising data, even in patients, are in ketamine nowadays. But ketamine actually suppresses cortical spread and depolarizations, but that does not mean that every patient should receive it. And we just had a discussion last year in Miami. I think the right patient population is the ones who have the clusters. So first identify the patients and then maybe adapt for a specific treatment. And for now, we are left for a very general answer. What should you do? Well, normothermia. I think that's a critical thing. So our patients should not come into fever, normocapnia, normoglycemia, and obviously treat all our critical care patients in terms of ICD crisis, hypotonia, and all the other causes. Thank you very much for your attention.